Thank you, Dr. John. One of the questions posed, number one is Dr. Kamaruddin with his COVID and how COVID affects the heart, that people get myocarditis, pericarditis, and maybe cardiomyopathy as well. So could you give us a little bit of what you can tell about COVID vaccines and the heart?
Yeah. So I think first of all, maybe we separate the two because there is the COVID and then there's the COVID vaccine. So COVID itself, as we know, predominantly affects the airways, affect the lungs, but it also affects the cardiovascular system. So this coronavirus can attack what we call the endothelium, which is the cells lining the arteries and the heart muscle, and it can cause these arteries to leak. So that's why, fortunately, it doesn't. Most of the cases do not result in that, but we have got cases where the COVID has affected not only the lungs but also affected the lungs, affected the heart, and caused myocarditis, which is inflammation of the heart muscle, pericarditis, which is inflammation of the lining of the heart, and because it has caused this blood vessel lining, including the coronary artery endothelium, to become unstable. It has also resulted in patients having heart attacks and heart failure. So this is from the COVID-19 infection, the coronavirus. And one of the reasons why the mortality is much higher in those who have existing coronary artery disease, if they get COVID-19 on top of their coronary artery disease, the risk of dying is a lot higher. So those are in the high-risk groups because it can trigger myocardial infarction and so on. So COVID-19 is not just a disease of the respiratory system. It's actually a multi-system disease. It can affect the heart as well. Now, this COVID-19 vaccine, it can, particularly the mRNA vaccine by Pfizer and Moderna, can also cause pericarditis. It's a different myocarditis and pericarditis. It is a different sort of mechanism. So with the mRNA vaccine, there's no virus, so there's no virus attacking the endothelium and causing heart inflammation and all. But there is an immune reaction, an autoimmune reaction, and this goes down to the cellular level. So the greater the immune response, the greater the risk of this myocarditis and pericarditis. So this vaccine actually is very safe in the older people and in adults, because the elderly particularly do not mount a very strong immune reaction to the vaccine. The risk of this myocarditis, pericarditis is highest in the younger patients, in the adolescents in particular. So those in the 15 to 17-year-old age groups have the highest risk of myocarditis. And that's why we took so long, in Malaysia, we took so long in authorizing the vaccine for the adolescents. So because of the data from the United States, from Europe, we knew very early on that the vaccine is very safe for the adults. But there was this concern in the younger age group because of the heightened immune response they mount. And the incidence of myocarditis is greatest after the second dose. So it's almost unheard of to have myocarditis after the first dose in adolescents. But after the second dose, there are reports of myocarditis in this teenagers. But even then, the incidence is very, very low. So you're talking about incidence of 3 in a million or something like that. So very, very low incidence, but it is recognized. And so what some countries have done is they've lengthened the interval between the first and second doses so that it's safer for the adolescents. Some countries have just licensed a single dose. But of course, as we learn more about this myocarditis related to vaccination, we now know, again, balancing the risk versus the benefits, because now we know the risk of COVID-19 is not just in the elderly, it's highest in the elderly, but we also have adolescents and children getting COVID-19 as well, and serious COVID-19. And a lot of this ending in hospitals and then spreading it in the community. Based on the balance of risk versus benefits, every country now has licensed the COVID vaccination in adolescents and now even down to the younger children. So there is a risk of myocarditis, but fortunately, unlike the risk of myocarditis due to COVID-19, which is serious, the risk of myocarditis due to the vaccine is usually very mild and usually self-limiting. But as in all treatments, there will be side effects, but fortunately the side effects are very minimal and the benefits from it are very large. So if you look at the risk versus benefit, they definitely favor the use of vaccines.
Okay, then we have a question when you were at on aortic stenosis and replacement of the aorta. Someone asked, what caused enlargement of the aorta and what are the symptoms?
Yeah, unfortunately with the aorta, often there are no symptoms until they are quite advanced, but it can run in the family. So a lot of the early aortic aneurysms or dilatation are picked up because patients have family members who have this condition, who have previously been treated for this, and so they go for a medical checkup. They have a CT scan or an echocardiogram to check on the heart and the aorta, and then they pick up this dilatation. By the time the patient develops symptoms, usually the aneurysm is actually quite big already, and the aneurysm can cause pain or chest discomfort. Because the aortic valve is also attached to the aorta, sometimes as the aorta gets bigger, it can cause that aortic valve to leak. And then when that happens, the patient can get short of breath. So shortness of breath and chest discomfort are two of the symptoms, and chest pain are two of the symptoms of aortic aneurysms.
Okay, the next question comes from Eunice. For a 15-year-old pulmonary atresia VSD patient, is mechanical valve works better than tissue valve? What is the cost? For example, how many percent or times more expensive than tissue valve? Is it common now?
This is quite a complex question because you are talking about surgery in children. Now, children, as we all know, are growing. So the heart will also have not reached the correct size yet. If you put in a mechanical valve, it's of course a fixed size. So you can have, it's difficult to say whether it's the best valve or not, but sometimes you have no alternative. If you do put in a mechanical valve, often it will be a small valve, and as the child grows, it may not be big enough for the child, and they may need further surgery. Sometimes the valve can be repaired, so it's not quite easy to answer that question. We have to, and those are a challenging group of patients who sometimes need more than one surgery. So surgery in children when they have when it's needed. Is often not the definitive surgery. So sometimes these children may need further surgery in later years. But surgery in adults often, fortunately, is just a single surgery. Of course, sometimes we need to do it more than once in adults. But most of the time, fortunately, we can just do it once in adults.
Yeah, thanks, Dr. John. There's another one that comes from Harry. He asked whether can plaque be removed by medication, or it will still build up over time, even with medication?
Yes, yes and no. It depends what stage we have caught the plaque. So in the early stages, before the plaque becomes very established, and definitely before the calcium starts setting in, it can be reversed sometimes with high-dose statins, but that is not consistent. So if you catch it early enough and there's only slight narrowing of the arteries, sometimes you can, if not reverse it, you can stabilize it and prevent it progressing any further. But usually once you have got very significant narrowing already, medication alone won't be sufficient to reverse it to the extent that blood can flow normally through the arteries again. So yeah, high dose statins can stabilize blood and reverse them to a certain degree if it is caught early enough. But those most of the time, by the time we see it, when the narrowing is very bad, then medications alone would not be sufficient.
Well, there's one coming from Mr. Chan HN. For a normal person at the age of 60, what are the representative screening tests do you recommend for state of health of his or her heart?
Yeah, I think at that age group, I think I didn't cover this in this talk because the topic was on treatment, but I think prevention is even more important. So a complete blood test is essential, looking at the risk factors for coronary disease. So like diabetes, high sugar should be controlled, cholesterol should be controlled. And of course, just a normal blood pressure measurement, hypertension should be controlled. So and then adjustment of the lifestyle, some exercise, even if it's a light exercise, should be done. And then avoiding smoking. So any of the risk factors should first of all be addressed. Then in addition, if you're in your 50s or 60s, it's good just to have an ECG. An ECG will often give us clues as to whether you have any underlying heart condition. And then just a doctor to listen to your heart, because that will pick up any problem with the heart valves. Probably it's good to just, if you've not had an echo scan done, just to have an echocardiogram scan of the heart, because that will see any problem with the heart function or the heart valves. And if you've got any symptoms, then a stress test, getting you to walk briskly or do a slow run on a treadmill, is also a fairly good non-invasive screening test for heart disease.
How about a need to do MRI besides BCG, ECG?
MRI only if you have a family history of particular types of heart condition. So if you have a family history of cardiomyopathy, for example, and which is a weak heart, and the echo shows that the heart function is not normal or is weak, then you may consider an MRI scan. But MRI is not usually done as a screening test for heart disease. We usually don't go straight for MRI scan, unless you're talking about MRI is quite interesting, because part of my PhD was on cardiac MRI, and we developed a technique to image the mitral valve using cardiac MRI. So cardiac MRI at that time, and even now, is primarily used to assess heart function, heart viability, and morphology in pediatric structural heart defects. It's never been used to measure cardiac, used to assess the mitral valve. So we developed an imaging protocol using cardiac MRI to assess the mitral valve. And to do that, of course, we asked for volunteers. So we had about 20 healthy volunteers coming for MRI scans, because we needed to image the mitral valve. So, so unless you're part of a research study where you go for MRI scan for them to develop new imaging techniques, MRI by itself is not a screening test. But MRI is very safe because it's just pick up magnetic magnet. There's no radiation or anything. It's only drawback is it's a very slow test, because it takes 1 hour. A cardiac MRI test takes 1 hour, and it's a little bit noisy. There's a lot constant beeping at the back, but they'll give you some headphones to play some nice music in. So, but to answer your question, cardiac MRI is useful as a second test after an initial test has picked up something wrong with the heart. Not usually done for screening.
There's one from Rosita Rosalie. I have a question, Dr. John. Can a moderately damaged valve caused by rheumatic
rheumatic heart
disease be cured?
It cannot be cured, but it can be prevented from progressing. So patients with rheumatic disease should be on antibiotics, should be on penicillin. to prevent the rheumatic disease from progressing and also from affecting other valves. So this rheumatic fever, which is still prevalent in Malaysia, particularly in the east coast of Peninsular Malaysia and also in Sabah and Sarawak. When I was in Kuching, we had a lot of patients with rheumatic heart valve disease. It's less common in the more urbanized cities like Kuala Lumpur because the rheumatic heart valve disease is due to an infection when the patient is young and not taking the antibiotics. So this bacteria triggers some inflammation in the heart valve which persists. So if you have moderate rheumatic heart valve disease, then it's important that you are taking penicillin to prevent the disease from progressing and affecting the other heart valves.
Yeah, the other comes from lung. Dr. John, in future, will there be a system whereby the narrowed or blocked arteries can be cleared by removing or clear the plaque?
Oh yeah, that's already in existence. So you can have we can actually through it's a form of stenting where before the stent is deployed, we can do ablation, rotablation or rotational atherectomy to clear. Essentially, it's a tiny little drill which drills through all the plaques, scatters them into small pieces. And then these small pieces disperse into the arteries. Now, there's a little bit of risk of that because you're not actually able to remove the artery. What you're doing is just you're destroying it and breaking up into tiny parts, and then it's all going out into the heart muscle distally. But at least it allows the blood to flow through the coronary artery. So this is done. This can be done in those patients who are not fit for bypass surgery. Usually when you need this procedure, the coronary disease is quite extensive already, but it's certainly one of the techniques for those who have chronic disease. Now, in the acute setting, if you have a heart attack, then there's fresh thrombus. Then there's a different technique actually we can use to remove those thrombus as well. So that is very effective because that is fresh, and you can remove the thrombus and allow the blood to flow through again. But in the chronic disease where the blockage is already very hardened, then it's a little bit more challenging. But it definitely can be done. But it's not suitable for everyone. And certainly the cardiologist will discuss with you the different options.
Yeah, then there's one from Emily Yong. Should there be more regular palpitations? Is it important to get a heart check? What are the probable causes?
Oh,
there's no smoking, there's no drinking, 6,000 steps per day.
Yeah, if you have palpitation, it should definitely be checked. It can be benign, but we have to know what type of palpitation you're having. So there are very benign types of palpitation, and which do not need any treatment. And then there are some more worrying types of palpitation which do need some treatment. So sometimes your palpitation and ECG may not pick it up, because when you have the ECG, you may not be having the palpitation at that time. So sometimes you may need to wear a monitor for a whole day, for 24 hours. You will be fitted with a monitor. You can go home and then you bring back the monitor the next day, or sometimes it's done over a few days. So we have a recording of what your heart is doing over 1 or 2 days. Then we will know what type of palpitations you're having. And depending on that, you may or may not need some treatment.
Well, there's one from CJ that asks, is myocarditis reversible?
It depends again what types of myocarditis. So myocarditis is a generic term which refers to inflammation of the heart. So vaccine-induced myocarditis is generally mild and self-limiting. COVID myocarditis due to COVID-19, we are not so sure about the longer-term effects, because some of these patients are coming back with long COVID. So we're still learning from COVID. We will learn more over the years, but we do not know about the longer term effects. But having said that, other types of virus do cause myocarditis. And in those other types of viral-induced myocarditis, they're usually self-limiting in short term. So some patients present with myocarditis not due to COVID, but due to other viruses. This is in the pre-COVID times, and they are in heart failure. And almost all of these patients will recover. So other types of myocarditis are alcohol-related. So important for those who drink. If you're a heavy drinker, it can cause myocarditis, alcohol-related myocarditis. Now, those type of myocarditis are reversible if you stop the alcohol. But having said that, there are always limits. So if the myocarditis has progressed so much and cause fibrosis to set in, then it may not be so reversible. So so it depends what type of myocarditis there is. Most of it, if it's early myocarditis, can be reversed, but some cannot be.
And if the risk of vaccination is very high, should we allow children to be vaccinated?
The risk is not high at all.
Oh.
The risk is very low. The risk is extremely low. You're talking about the whole country being vaccinated. If it is a high risk, we would know about it by now. There will be lots and lots of patients going to hospital because of the vaccine, but we're not seeing that. The risk is very low. We have got more than 90% of the country already being vaccinated. So.
Okay, another one on stents. Huh? Can narrowed implanted stents be replaced or cleansed?
The narrowed stents, they're not usually replaced because the only way to take out a stent is to remove it at surgery. Sometimes we have to do it if the unfortunately some patients have had the whole artery stented and then the stents block off. So the only way to then restore blood supply to the heart is to take out those stents. But generally it's not done because patients who have bypassed after stents, usually we can bypass put a new graft after the stent. But sometimes if there's no place to put it, then we have to take out the stents, but that is quite unusual to do it. There's no other way to take out the stents. You can do this drilling through an existing stent, but usually once you have had a stent and it blocks off, the results are really not good if you try to drill through narrowings within an existing stent. So usually those patients would be more suitable treated by bypass surgery at that stage.
What causes heart arrhythmia? And, oh, I lost it. What causes heart arrhythmia?
Heart arrhythmia meaning problems with the normal conduction of the heart. So I'm not covered that.
Can it be cured?
Yes. So I haven't covered this again. So the heart is a pump, and for the heart to work, it has to receive its electrical signals. So the conduction to the heart. So there's the conduction tissue, the autonomic nervous system, which brings impulses to the heart, electrical impulses. So sometimes there can be abnormalities in this electrical conduction to the heart. So to what we call arrhythmias, which is the question. So arrhythmias can definitely be treated, usually with medication in the first instances, because often you just need the right sort of medication to regulate the electrical conduction of the heart. Sometimes those are not sufficient. Then we can do procedures like ablation procedures to redirect the conduction appropriately, because some patients have got extra conduction tissues to the heart muscle, and then some of this conduction are going through these extra conduction pathways. So sometimes we may just need to direct the conduction appropriately. Sometimes the arrhythmias are due to the hormones. So if you have an overactive thyroid, for example, that can cause arrhythmias. So patients with arrhythmias, so first of all, we have to see, arrhythmias are basically the technical term for palpitations. So if you have that, proper medical evaluation is necessary, including blood tests for the risk factors and also an ECG to determine what type of arrhythmia and then it can certainly be treated either with medication or some additional interventions.
From Kok Meng, Dr. John, material, oh my God, you ran away. It's kind of material engineering versus biomedical engineering. Which one is more relevant to medicine?
Both are important. Both are important. So a lot of our medical devices rely on biomedical engineering to develop and maintain. And then a lot of the devices depend on medical engineers to help us develop the device. The heart valves, for example, I've not covered the whole spectrum, but we have got assist devices, which is artificial valves, pacemakers, and all. So doctors actually have been helped a lot by the supporting professions like engineers and to come up with the right sort of devices to provide the right sort of treatment.
How does stem cell works in the rejuvenation and blood circulation of our heart?
This stem cell is a big topic. So the stem cell refers to the origin of the cell lineage. So this what we're talking about, we've been trying to do this for many years to somehow help a failing heart grow new heart muscle to replace the weakened heart muscle. So, and there are various techniques we have been doing to try and introduce these stem cells into the heart muscle. So one of the techniques is to inject stem cells during a coronary angiogram. So when you have the catheter in the coronary artery, studies have been done to inject stem cells into the coronary arteries to see if it can be taken up by the heart muscle to get it to go stronger. Another way to do it is we have also tried to inject it during surgery. So when we do surgery on a very weak heart, after the surgery, we would then inject some stem cells into the heart muscle. And then a third group have been trying to inject it in the peripheral circulation. Now, unfortunately, none of these techniques have been shown to be working at the moment. So they're all still very experimental. The problem is we have not been able to get these stem cells to be taken up by the heart. So we've not got what is called an effective scaffold for these stem cells to latch on and then to start growing and to reproduce into properly functioning heart muscle. So that is an evolving technology. When we do discover it, when we already discover stem cell, when we do discover the means for these stem cells to be taken up by the heart and to be incorporated into the heart, the person who discovers that will, I'm sure, win the Nobel Prize. But we're not quite far there yet with stem cells. There's some practitioners selling stem cell treatment. They don't work for the heart. I can tell you that, not at the moment anyway. The research is still ongoing for that, because the problem is the stem cells, we can introduce it, but we can't get them to stay where it needs to stay to help the heart to get stronger.
Yeah, thank you, Dr. John. You have got lots of things from so many people at the chat. People have conveyed lots of things to you. Very informative, very good work. There are lots of it.
Thank you.
And we have passed our timeline.
Yeah, thank you. Thank you for the invitation. And once again, it's really a pleasure to.
In fact, there's a lot
thank
more
you
because
much.
you have not spoken on the drugs, the newer drugs.
Yes.
There's a lot more,
Yes.
you know,
It's
on the
a big topic.
pacemakers, the CRTDs. We just don't have the time. But it was very interesting. I thank you very, very much, Dr. Chan. BGAM and our committee, we are here to assist our audience on this social platform, but we are not drug peddlers, nor do we have any interest to pursue on a material platform. If you have any problems, it's best you contact your medical practitioner. But if you need something, maybe Dr. John can help you further. I thank you, Dr. John, on this span day, which is your rest day, and you work solid days. I wish to thank you for having spent your precious hours with us. And maybe whether our president, Dr. Kamaruddin Ali, would like to give some words, or Mr. Raymond Chan would like to wrap up.
No, I think I think you have done a great job, Dolly. Yes, again, on behalf of BGAM, we'd like to thank you, Dr. John Chan. You have done a splendid job. I think there are still many questions to answer, but that is how life is. I think we shall proceed to end this session. Thank you very much, Dr. John.
Thank you, everyone.
Thank you,
Dr.
very
John
much.
Chan. Thank you, the MC. Thank you, Dr. Kamaruddin. And thank you, our group of BGM committee members who have made this successful.
Thank you.
Bye. See you all.
Bye.